Hi, my name is Dr. Peter Tawil from the Beirut Dental Specialist Clinic, and I'm going to present to you today a case that I showed previously on our Facebook page. It's actually the case taken from A to Z, and I hope you enjoy it. This is our team. We are dental professionals. We work with a team of periodontists, oral surgeon, prosthodontists, endodontists, and general dentists, where our multidisciplinary approach of cases allows us optimal aesthetic results. This is our team again, and you can find this lecture on bdsclinic.com. So the case again, it's about the tooth of a central incisor of a young 24-year-old female that came in with a chief complaint of a periapical abscess on the central left incisor, as you can all see clearly on the screen. She's, of course, a very beautiful lady with a high smile line and very thin biotype, as you can clearly see here on the lower right side of the screen. She is suffering from a periapical ptosis on tooth number 21, and so she wanted to see what we can do about this. First and foremost, classify the patient as part of the aesthetic risk factor chart, and this is taken from the ITI consensus in 2004. Very important chart, which I recommend all the surgeons out there to use whenever they are engaging themselves in implant therapy. So either you classify your patients into the low risk factor, medium or high risk. Therefore the different therapies will guide your treatment differently. If the patient, for example, is a low risk in the aesthetic risk factor, you could go with the more advanced and more pushed therapeutics, more immediate loading, more pushing the envelope more, whereas if the patient is a high aesthetic risk factor, you probably want to go for a more conservative approach and stage your procedures and build up bone first, perhaps soft tissue later, to achieve optimal aesthetic results. Here in this case, we can clearly see that the patient is in the high aesthetic risk factor, knowing that she's healthy, she doesn't smoke, but her expectation of the treatment is high. Remember well, she's a very attractive young female, and she has a high lip line, which is of course a high aesthetic risk. She has a high and thin scallop biotype. The shape of her teeth are triangular, and she has an acute infection on the site. The good thing of this case is that the adjacent teeth on the both sides of the deformity is actually sounded. She has less than 5 millimeters between the contact point of her adjacent teeth, which is good, and this will guide us to an adequate interdental papilla. The restoration of the adjacent teeth is non-existent. The teeth are virgin, which is good too. She has only one tooth of edentulous span, which is also a good asset on our side. However, the soft tissue has some deformity, and we can definitely tell that she has some kind of a bone deformity, since she has a sinus tract fistula on the buccal aspect of her central incisor. So, going back to the case, the clinical findings are definitely a periapical ptosis. Upon clinical examination, we definitely realized that the root was fractured, since with the probe we had a drop of about 12 millimeters on the mid-facial of the buccal plate. She definitely has a thin biotype, high smile line, we can tell that. Her bite is almost normal, with 3 millimeters of overbite and overjet about 2 millimeters. and she's class 1 occlusion. So no occlusal deformities, however local deformity. So what we did next was extract the tooth in question with the use of a periotome and exotome, and extract it as minimally invasively, and curetted the site, rinsed with the hydrogen peroxide for a couple of minutes. Then this picture shows clearly the deformity of the buccal plate, where it's practically non-existent in this case. We then sutured the site and let it heal for about 6 weeks. As I was referring before to the risk factors, here we decided to stage the procedure and to wait about 6 weeks for some soft tissue closure, and perhaps go back in and place the implant with the bone graft to rebuild the site. This is the site sutured. This is the tooth, and you can appreciate the vertical fracture clearly seen in the photograph here on the lower right hand side. This is about 6 weeks later, where the patient came back. She was using a flipper as an interim prosthesis in between. The site has healed. This is the radiograph of the site. We had some soft tissue growth, and since we knew that she had a vertical and some horizontal mainly and some vertical bone deformity, we knew beforehand that she was going through, she was going to go for an implant plus a bone graft to rebuild the buccal plate. And this is when we accessed the site for implant placement. A mid-crestal incision was done with the vertical release on the distal aspect of the central incisor. Access to the site was curetted. The granulation tissue was taken out. This is the implant drilling, and of course we started to place the implant ideally in the three-dimensional space. The implant emergence has to be towards the palatal side, as much as possible towards the cingulum of the adjacent teeth. So if you draw a line in between the central and the lateral incisor, the implant has to come somewhere in between these two lines palatally as much as possible, to allow some soft tissue and for the ceramic to be able to hide that abutment from the soft tissue. The implant was placed accordingly also to the adjacent cemento-enamel junction. Here the bone is about 3 millimeters away from this cemento-enamel junction, so a bit more, 4 millimeters here. So we placed the implant only 2 millimeters away from the cemento-enamel junction, as you can see here. Some of the implant threads were exposed, and we then decorticated the bone, knowing that of course we had to graft on top of that implant. The implant was placed with a very good torque, about 35 Newton centimeters, and it's a Straumann bone level 4.1 by 12 implant. So after decortication of the buccal, what remaining of the buccal plate, we then decided to graft the deformity with a xenograft. This is it, as you can clearly see, about 2 to 3 millimeters of thickening to recreate that lost space. The implant position is ideal, so palatally oriented, with a nice tilt towards the distal to recreate the zenith of that central incisor. The whole thing was covered by a collagen membrane to adequately complete the guided bone regeneration. The flap was then sutured hermetically with the 5/0 vicryl, and we allowed the whole thing to heal for about 5 months. This is at about 2 months later, when the patient had the provisional tooth bonded to the adjacent teeth, so no pressure was done on the flap. We allowed, of course, for more than that for the healing, about 5 months, as I said previously. This is the profile size shots, as you can see, distal and mesial. You can discern some deformity on the buccal plate, but it has been restored. And now at the abutment connection, we decided not actually to place a connective tissue graft, which you can criticize on that or not. Since we knew that we would have a great contour of the teeth, we could have probably placed a connective tissue graft to bulk it up a bit more, but in this case, it wasn't necessary. This is the final result of the implant after, of course, a provisional phase in which the tissues were pushed out buccally only by pressure, and to adequately create that contour and preserve what was rebuilt of the bone. And this shows clearly with a great tissue match, a great interdental papilla that is present, and of course a great ceramic work done by the referring doctor. This is a side shot of the same final result with a great tissue blend, a great adaptation of the papillas, and the color. Both pink and white aesthetic scores are great in this case. And the radiograph showing perfect integration of the implant and a perfect emergence of the crown. This is an occlusal view showing a complete restoration of that buccal plate, and a perfect tissue blending where you can't really tell which one is the natural tooth and which one is the implant. And this is her smile. She was thrilled, and the patient was very happy to have her tooth back. And finally, this just like look at before and after. The patient came in with a huge acute infection. It was a very challenging case, but the fact of properly diagnosing the case, properly staging the procedures, and of course knowing how to set each stage at the perfect tone, where we first built up the bone with some xenograft, and then allowed for proper maturation of tissues, and then pushed the tissues buccally to recreate a proper contour. This is a small comparison. If you draw a line in between the canines and the lateral incisor, you can see originally there was a little step in between the left central incisor that was treated and the right central incisors. And if you recreate that same line on the final photograph, that step is conserved. So the case came back to the contours of the crown came back to its original position. And I can really tell you, I'm very proud of that aesthetic result, and the patient was also very, very proud. And of course, you can any questions you have, you can ask us. This is our website. It's bdsclinic.com, and I thank you a lot for your attention.